My name's Andrew Hurst, and I'm basically a media specialist at the Global Fund, and I'm one of a number of people who are like spokespeople for the organization. And I work primarily with media and media outreach and communicating what we do to journalists and people such as yourself, who are curious to know what we're doing and the work that we do to fight AIDS, tuberculosis, and malaria, which, as you know, are three very high burden diseases in a number of developing countries, but they hit sub-Saharan Africa particularly hard, and that poses a huge challenge for these countries.
So we talked to the right guy. I mean, do you have a lot of documentary filmmakers come in and talk to you? Or?
We do, yeah, we do, and we also have people who are interested actually in making documentary films, where we are active in the field. In fact, late last year I took a group of Spanish TV documentary makers to Tanzania, and they took a look at some of the programs we were doing there to support orphans, because often it's forgotten that in countries which have had HIV, AIDS epidemics, I mean, people tend to concentrate on the disease itself and the fact that obviously many people have died from this illness, but it's left a huge and a very heavy burden for these countries in the form of orphans. Mm-hmm. And in countries like Tanzania, there are about 2 million children who are basically orphans who in many cases have lost one or both their parents as a result of the HIV/AIDS pandemic. And so it's a huge challenge providing support to these children and ensuring that they can go to school and have a reasonable chance in life of leading a normal, productive life and having a normal lifespan. And that's very difficult in countries where social security systems are very weak, health support systems are weak, and where these children are growing up in families which have basically been devastated by this pandemic. So that's, as you can imagine, it's taken a lot of thought, a lot of organization to try and organize programs which help these. Children.
Because we're going to Tanzania, where do you guys have some programs at?
Well, all around the country, really.
Do you have any in northern? Because we're going to be going. We're basically going from Rwanda to possibly Zanzibar, and then up to Mombasa, then back to Nairobi.
Yeah, in the north of the country. In the north of the country, we could certainly, I can show you exactly where we have some programs, but we have very interesting programs in some of the mining communities up there. Mining is a big challenge in a lot of African countries because it attracts a lot of migrant workers, and it also attracts prostitution because a lot of the migrant workers are young, sexually active males who are on their own, and they earn money, and then they like to let off steam, and they tend to drink, and they can also have sexual relations with sex workers, and often that leads to taking big risks with their health because they don't often take the adequate precautions. And so often mining communities have been magnets, if you like, and have raised all sorts of challenges for the health authorities.
What cities are you in? Arusha or anywhere between?
Well, Arusha, around there. And Dar es Salaam as well.
Maybe afterwards.
Yeah. I mean, we probably need to look at a map, and I can show you exactly
that'd be
where
great.
we're active.
We'll do that
I'd be more than happy to do that.
Okay, so I've definitely heard about the Global Fund before. What I heard about first, I think, was the Red campaign.
That's right.
I heard about the Red campaign. I was like, I wonder where all that money's going. And
right.
That is the majority. Can you talk a little bit about that, the Red campaign and the Global Fund and how they...
Yeah, well, actually, the Red campaign, I mean, most of the funding that flows into the Global Fund, and the Global Fund has now committed something like $16 billion to programs, in something like about 145 countries.
I guess first, before we go in there, what does the Global... I mean, are you guys just a foundation that gives grants to other organizations, or do you do tangible work yourself?
We're essentially a financing agency. basically 95% of the money we have comes from governments, primarily governments of rich countries like the United States, like many of the members of the European Union, countries like France, Britain, Germany, Italy, Spain. So that's where much of the funding comes from. But we also raise some funding from private foundations like the Gates Foundation, and from private companies. Chevron, for example, the oil company, is involved in a particular program with us. And you mentioned the RED program, and that's probably one of the sort of more original programs that we've engaged with in order to raise funding. But we can come back to that in a minute. But essentially what the Global Fund does is we're a financing agency. So we basically we solicit proposals from countries like many of these countries in sub-Saharan Africa, which need funding so that they can scale up their programs to fight these 3 diseases. And essentially what we do is we encourage them to, they form these kind of panels, in-country panels, which represent different sectors of, the government, people who are affected by these diseases, who are living with these diseases, NGOs, and they basically come up with a proposal which they send to us, and we take a very close look at that, and they solicit funding. And based on the quality of the proposal, more often than not, we approve the funding and we hand out the money. And the money is handed out over a period usually of 5 years. And it's basically it's results driven. In other words, the money that we give to these programs is basically hinges on these programs being managed properly in a transparent way, and the money being spent on the way it should be spent. So there's absolutely zero tolerance, for example, for corruption or any misappropriation of funds. And we're constantly monitoring the performance of these programs, because the donors, countries such as the United States, are obviously very, very concerned that the money that they are donating to these programs is well spent, and it goes to the people who need that help.
How much do you think of, say, for America example, how much do you get? Is it from our foreign aid? Is it from the bills like PEPFAR? How much of what the U.S. government is trying to do, or even U.S. people in general are trying to do about HIV, how much is that going through the Global Fund?
Well, quite a significant amount. I mean, as you rightly said, you mentioned PEPFAR, which was set up by former President George W. Bush, and that is, the president's own initiative. That's the United States bilateral program. But a significant portion of PEPFAR monies go to the Global Fund, which is seen as the sort of from the US perspective, is seen as like the international arm of PEPFAR. So essentially the United States is co-financing the Global Fund together with other countries, primarily countries in the G8, and I mentioned some of them before. France, for example, is the second largest donor after the United States.
So the United States is the largest donor?
It is the largest single donor.
Do you know how much the U.S. gives?
Well, it accounts for something like 28% of our funding, and as I said, $16 billion has been committed by the Global Fund to various programs since the creation of the Global Fund, and the Global Fund has been in business since 2002, so for just about 7 years. So it's still a very young organization.
How did this young organization, I guess my question would be, if I was watching this, how did these guys get all the money? Why are these guys making the decisions, I mean, how did the Global Fund get this position?
Well, I think that's a very good question, and I think this basically started from a situation at the turn of the millennium where already in countries such as our own, and let's not forget that the United States was the first country in which HIV/AIDS was identified as a disease. You'll remember in the early 80s on the west coast of the United States, I think specifically in San Francisco, is where the first cases of HIV/AIDS were diagnosed, and it was only in subsequent years that the gravity of the situation emerged in sub-Saharan Africa, and where the disease spread like wildfire. And I think one of the things that this showed is that while nobody, rich or poor, is immune from contracting, from getting a disease like HIV/AIDS or malaria, for that matter, richer countries are in a much stronger position to respond to these diseases. I mean, to give you a specific example, when AIDS was first diagnosed, and I remember well, in the 1980s, there was sort of mass hysteria. People thought that you could catch, you could become HIV positive simply by touching somebody who had the disease. And so people were reluctant to get on a plane with anybody who was identified as HIV positive, for example, and people just thought it was highly contagious. And one of the reasons people were so terrified was that there was no cure. And in fact, there was no successful treatment of any sort at the time. And it wasn't until 1996 that a treatment was developed which doesn't provide a cure, but it does allow people to lead a fairly normal life and a productive life if they start the treatment early enough before the disease has progressed too far, and they stick to that treatment. But the treatment is not cheap. And particularly when it was first developed in the 1990s, it was extremely expensive. So the problem was that in countries, in rich countries like the US and in Europe, where the need wasn't as great, there was pretty much universal access to this treatment. People could get that treatment pretty much for free. But where there was the greatest need, primarily in sub-Saharan Africa, but also in countries in Asia like India and China, which have significant problems with this disease, most people just could not afford the treatment. While this is not a disease specifically of poverty, it is a disease which poor countries, and particularly the very poorest people living in poor countries, are most exposed to and most vulnerable to and most unable to find treatment. What happened was that there was a growing realization that the problem was out of control in parts of Africa primarily. And as I mentioned earlier, the prevalence in some countries, like in South Africa itself, was over 20%, which is staggeringly high. And that means that if those people, and we're talking about 1 in 5 of the adult population, are not treated, it's only a matter of time before they develop full-blown AIDS. And if AIDS is not treated, then it leads inexorably to those people dying. So there was a realization, I think, on the part of the international community that we had to mobilize very, very significant amounts of money in order to attack this problem. And that really is the origin of the Global Fund. And a decision was taken just over 7 years ago, 8 years ago to be precise, in Geneva, at a G8 meeting in Geneva, Italy. And there it was decided to create this fund, and which would allow an accumulation, a concentration of resources, which could then fund programs both to prevent the disease, but also to treat people who already are, specifically in the case of AIDS, were already diagnosed as HIV positive.
The G8 did this? There was the G8?
This was the initiative. This was the initiative, yeah. And then subsequently, initially it was members of the G8 put up the initial money. They made the initial contributions, and then other countries agreed to donate and make significant donations on a continuing basis. Because I think one of the other things you have to remember here is that the Global Fund isn't a charity; it's essentially a global health aid agency, and you need constant flows of funding in order to achieve results. You cannot have funding that's at the mercy of the economic cycle. For example, if our funding sort of plunged now at a time of economic crisis, that's just the time when a lot of countries, which poorer countries, are feeling the pinch hardest. And so their populations are most exposed. Many of them are losing their jobs, and it's putting more stress on their health systems and so on. So you need constant flow of funding in order to, first of all, to put these programs in place of providing prevention and treatment for the disease. But you also need to sustain this over a very long period of time, because these are not diseases that you can beat in a short time. We're talking about many, many years before we can really turn the tide here.
So is it an NGO? Is it a governmental organization? Like, who did they decide? How did they decide?
It's a public-private partnership. That's what's it called, a public-private partnership. But the public part is at the moment much more important than the private part. That is, despite our efforts to raise private funding from private sources. We're talking about very large amounts of money.
That's probably all we need to
do. And obviously we hope that the proportion of private funding will rise in time. But I still think that the bulk of the funding is going to come from the public sector. Is going to be coming from governments. Now, you mentioned RED. I think RED is a very, very interesting program, because it provides a kind of sustainable way of providing private sector funding. Because essentially what happened was Bono and Bobby Shriver, I think, who came up with this idea, they invited various companies, and each of these companies is sort of representative of a particular area of business activity, like Microsoft, Dell, The Gap, American Express, Armani. There are various other companies. Starbucks joined recently as well, and I think other companies are going to be joining in the not too distant future as well. Essentially, they identified certain branded products which they called RED products, and which are branded as RED products. And basically, the profits, or part of the profits from any sale of those particular products, flows into the Global Fund, and basically supports programs, a number of programs which we are supporting in Africa. Well, until now, it's raised more than $130 million. That's in about 2 years. So, that's a very, very satisfactory result. It's still, relatively small proportion of our total funding, but it's very significant, and it's growing. That's the most important thing. And also, provided more and more companies can sign up to this program, and we can sustain the momentum and make people like yourself aware that you can actually go into a store and buy products which, you're not doing this solely for charity, because you're buying something that you want to have and you want to use. It might be an iPod or a cup of coffee or a pair of jeans or whatever. But that in so doing, you can actually contribute to a very, very fine cause, and a cause which is actually achieving very significant results. And I think maybe I could tell you a little bit about the results that we're starting to achieve now.
Sorry, I see that. Well, before we get that, like the RED, it seems great, because people are getting, it's always great when one side's getting what they want, and so is the other side, and it's just mutually beneficial.
Exactly.
I think it's a great combination, so I love the idea, but I also have heard people who are skeptics of it, and I don't even know exactly, maybe they were like, well, some of the organizations aren't doing good in these other areas of so they would mention an organization, but they also, child labor or something like that. I don't know too much, but I'm sure you know the skeptics better than I do, and could you address who's ever the skeptic?
Well, I'd need to know. I mean, obviously, I'd need to know exactly what people are skeptical about. But I mean, I hear you loud and clear, and I think I know where you're coming from. I mean, perhaps you mean that some people are skeptical about those companies. And some of those companies, and I don't think this applies to any of the companies which are involved in the RED venture, but of course some companies are more controversial than others, and there have been issues surrounding labor, use of low-cost labor, and these broader questions of corporate social responsibility. I mean, but I think my answer to that is, let's focus on things that people are getting right. Nobody gets everything right, and some companies make mistakes. But I think in most of the cases where controversies have arisen of that nature. It's been openly discussed. We live in a world where you can't hide much these days, particularly if you're a listed company. And so if there are issues around labor and that kind of thing, use of child labor, for example, that gets pretty openly debated pretty quickly, and companies are very sensitive about how they are perceived by people who consume the products and by the public generally, even by people who may not actually buy whatever it is that they have to sell. So I think our feeling is, we are a very fine cause. We're mobilizing resources and channeling into these highly effective programs, which are helping countries fight and roll back these devastating diseases, and helping them build a more viable future for their own societies. And the companies that sign up for RED are helping us achieve that goal. So I have nothing but praise for those companies that do that, and all I can say is, I would hope that more companies, sign up for these programs. And,
I would.
I think everybody has something to gain. It's really, it's hard to see a downside to something like this.
Yeah, I know, because I was wondering.
I think they're two separate issues. If we're talking hypothetically here, but any number of companies may have issues around how they produce their products, what their cost structures are, how what countries they happen to be producing in, and what are labor rights in those countries, or union rights, or what have you. But I think that's a separate issue from encouraging consumers to go in and buy products in the knowledge that products which may be of use, which they would buy anyway, are actually helping raise funds for a cause that is you can find out about. You can actually see how that money is being spent.
Yeah, I just wanted to. Just wanted to ask that question that I know is out there, and some people would want to ask, and we've dealt with that too. Like in the beginning, we were thinking about getting like a condom company to sponsor us. I don't know if you remember that. And it's like, well, the conservative people, they might be issues with condoms, and it's like, well, how much is that our problem? I mean, if this company decides to support what we're doing, do we, And so I understand what you're saying. I just wanted to ask that question. So
No, you should.
Just to ask other people's questions, and so let's hear about like some of the effectiveness, because it's just like the Global Fund is obviously it's huge. I mean, some of the biggest governments are pouring their money in it. Some of the biggest celebrities are supporting it. Yeah. And I heard about it from the RED campaign and all that.
Right,
so
right.
Tell us about the. How's it been going?
Well, I think one of the areas where we've seen really significant impact is in treatment. I said, as I was telling you before, antiretroviral treatment has been around now for well over a decade. But it was just prohibitively expensive for many people in these developing countries, particularly in sub-Saharan Africa, where a lot of people live on barely $1 a day. So you can imagine the cost of paying for treatment, which costs, which 10 years ago cost hundreds of dollars a month. Although those costs have come down very significantly, they're still completely out of reach of the pockets of most people in these countries. So what we have done now is that we have funded programs which allow for this medication to be distributed free of charge. In many countries, we are now on the way to approaching universal free access to this kind of medication. We're not there yet, but we're on our way. Wow. And I think one of the things, to give you just some raw numbers, about 2.3 million people now, primarily, nearly 2 million of those people are living in sub-Saharan Africa, are currently receiving antiretroviral drugs. And that basically allows them to live pretty much normal lifespan. If you are diagnosed, the latest studies show that if you're diagnosed as HIV positive and you're diagnosed early, let us say in your 20s, in the prime of life, it appears now that if you start treatment early enough, you can actually lead almost a normal lifespan. So it's basically become a chronic disease. It's a disease that you can manage. The disease doesn't go away. Nobody's found a vaccine yet. Nobody's found a total cure for this disease, but you can sort of keep it at bay. A bit like diabetes or something like that. It's something you can treat and you can lead an almost normal life. So this has had, beyond those numbers, it's had a huge impact.
And that's 2.3 million for HIV?
Yeah,
that's 2
right.
million, so that's
over 2 million people.
What would that be? That would be
2.3 million people.
That'd be just under 10% or something of the population.
Yeah, I mean, that's right. Well, that's right. I mean, worldwide, the number, I think UNAIDS talks of about 32, 33 million people who are diagnosed as HIV, with HIV/AIDS. Now, of those, at the moment, we believe that if you combine the numbers that we are funding, those 2.3 million, with PEPFAR, which is funding another, the two organizations together, we believe something like approaching 4 million. We're not sort of between 3.5, 4 million people are on treatment as a result of the funding from these two organizations, PEPFAR and the Global Fund. And there are other programs too, which are involved.
So it's more than 10% that we're reaching with these.
Yeah, but of those, remember that at the moment, the current sort of protocols are that you don't, if you're diagnosed as HIV positive, you don't have to start the treatment straight away. Basically, when the CD cell count, they are basically laboratory tests that you can conduct, and there are certain sort of triggers where treatment becomes mandatory. When the CD cell count, which is a measure of basically the burden of the disease, reaches a certain level, then it's considered absolutely mandatory to initiate the treatment, assuming that treatment is available. And we believe about 1/3 of people who need the treatment now, particularly in sub-Saharan Africa, are getting that treatment. So that's compared to 6 or 7 years ago when practically nobody. It was just a few thousand people who were wealthy people who could pay for this treatment themselves, but practically nobody else was getting that treatment. So this is a very, very significant change. It really is a revolution. Now, if we're able...
Is your organization, so, I mean, how much of a role are you playing in that 1/3? I mean... In that
1/3, about, I would say, over half of that. I would say...
So you're
yeah, it is.
Is the largest...
Yeah, it is actually, I think, the largest proportion of people on, we're funding the largest number of people who are on these health programs. And the thing you've got to remember that, taking ARV treatment, it's like riding a bicycle. If you stop pedaling, you fall off the bicycle. If you stop taking ARV, you then run a risk, if you suspend the treatment, of developing, over time, full-blown AIDS. So you have to continue this treatment. While, there is no cure yet, we hope eventually a cure will be found, but I think we're quite some way from that. And, it's for a scientist really to answer that question, rather myself. But, the experts say we are some way still away from discovering a full cure. While that is the case, we have to provide this treatment, and that treatment must not be suspended, which brings me back to the point I was making before. These funding flows have to be maintained. It's absolutely vital that the funding continues to come in from countries like the US, your own country, countries like my country, Britain, France, and increasingly, we're going to be looking to other countries, which are some of these emerging countries like, China and India, and which have significant problems of their own. They're not. Their economies are growing very fast, but they're not considered rich countries. But they are countries which are on the way to becoming fully industrialized and richer countries. So there will come a time in the future where I think even these countries will be asked to. The question will be put. Maybe they need to consider if they could perhaps contribute to these programs. And Russia is another example. Brazil, the so-called BRIC countries. Brazil, Russia, India, and China, which have been identified by economists as countries which are, in the coming decades, are likely to become very rich countries and significant influential players in the world, in global politics.
our documentary, it's focused on extreme poverty. It's focused on that 1.4 billion people the World Bank says live on $1.25 a day.
Right.
And what we're trying to figure out are the causes and the solutions of extreme poverty. And I was just wondering if you could talk about the role of disease, specifically HIV, malaria, and tuberculosis, how they play, what role do they play in the cause of extreme poverty?
Yeah. I think they play a huge role. I think that's a very good question. I mean, it goes to the heart of the problem. I think disease and obviously malnutrition is another very important part of the equation. But you're on your way to Africa, right? And none of you, as I understand, has been there before. But I think when you travel around Africa and you visit villages and you see the scale of the poverty, you see, coming from countries like, America or my own country, you definitely see poverty.
And we've been to Africa.
You have,
yeah.
So you do. You've
we've
seen
been to the Kibera slum in Kenya.
Right. Okay.
And speed.
Yeah, I mean, I think, well, as you were explaining, you have been to Africa, so you've seen some of these things for yourself. I mean, when you see poverty in our own countries, in North America or in Europe, you go into these areas, but no matter how acute the poverty, you do get a sense that people can actually, with a combination of a bit of luck, a bit of hard work, and a bit of help, they can actually claw their ways out of poverty. But very often when you visit some of these communities in rural Africa, the scale of the poverty and of the malnutrition is such that you sometimes wonder, how do people ever get out of this? Many children are not able to go to school, so they don't get a proper education, and without education they don't have the most basic means to improve their lot in life, and then they're at risk of disease and so on. So I think that poverty has many causes, but disease is both a cause and a symptom of poverty. And I think where the Global Fund can play a huge role is that in countries which have many problems and many problems on their hand and many sort of problems to deal with of poverty, trying to educate their populations, trying to feed their populations, if we are providing them with help and to build really well-targeted programs, effective programs that allow them to roll back these most devastating of diseases like malaria, like HIV/AIDS and tuberculosis, then we're giving them a leg up, if you like, in their fight to improve the lot of their populations. And I think, for example, in many of these countries, it's not just a question of helping them to fight those diseases, it's helping them to strengthen their health systems, healthcare systems, which are very fragile in many cases in the first place. And when the HIV/AIDS epidemic was at its height, in the 80s and 90s, a lot of the hospitals were flooded with patients. So basically the hospitals were just completely overwhelmed with this program. Now, the more people you have on treatment, that's people that don't have to occupy hospital beds, but actually can go back to their homes, can live with their families, can help support their families, particularly if they're of working age, and who can help stabilize these economies and help those economies to grow. If you don't have even the most basic care, healthcare for these people, they're imposing a huge burden on these healthcare systems, which are kind of pretty fragile and tottering in the first place. That's the first thing. And then part of the work that we do, it doesn't involve only funding the purchase of drugs, but it's also training health workers. For example, in Ethiopia, we're helping to train, it's a very interesting program of so-called health extension workers. These are something like 30,000 people. They're nearly all women who've been trained, and they work in villages throughout the country in these small they're called health posts. They're just 2 people work in each of them. They're little, like miniature clinics, which can provide.
They're called VCT centers, or?
Yeah, they provide counselling and testing, but they also provide medication for malaria and for ARV. So basically, they're like a first point of entry into the health system. And many of these villages are so isolated that this is the only chance that people have of any sort of healthcare whatsoever. So this has been a huge extension of of a country like Ethiopia, which is it's growing quite fast economically, but it's still a very, very poor country with huge poverty and 85% of people live in these rural areas, and they're now getting access to, thanks to training that's been supported by the Global Fund, to basic healthcare.
It's interesting that you bring that up because there's three of us. A cameraman's meeting us in Kenya, but when I was in Kenya, I met this guy named Tony, and Tony was studying to be an HIV counselor and do testing, and so he's certified in one of those VCT centers, and he wants to start one in Kibera, in the second largest slum in Africa. So that's interesting to get to talk to you about that. How would a guy like that get a loan from you? I mean, he's just a guy that lives in a rural slum, or lives in a slum in Kenya, and he wants to start a center. I mean.
Yeah, we can't. I mean, we can't actually. It's quite difficult for us to just give funding to particular individuals. I mean, basically, the country Kenya has to come up with a program, and basically, as I said, we provide the funding, but we don't actually manage the program on the ground. We basically, the country, Kenya itself, in this case, would appoint, with our agreement, an entity, an organization to implement that program, and it's a kind of project manager. We call them a principal recipient, but they then subcontract a lot of the work, and a lot of these sub-recipients, as we call them, these kind of subcontractors, some of them are faith-based, religious organizations, some of them are international NGOs, some of them are American in origin, some of them are international agencies like, UN Development Program. It varies from country to country, or sometimes it's the Ministry of Health of that particular country. It depends on everybody's best judgment of who's best qualified
so he would go
to deliver that program.
He would go to them.
He would need to go to them.
Okay.
He would know to go to them. But there are cases in point. I mean, for example, coming back to Ethiopia, which is a country I visited, I took some Italian journalists there recently, just several weeks ago. There are some interesting programs where we are helping to provide sort of sustainable funding for people who either living with the disease or who have suffered as a result of HIV or other of these diseases. I mean, for example, in Addis Ababa, we're supporting some very interesting programs. One of them involves former sex workers, and I remember visiting. It was a bakery, and they were provided seed capital, and we're talking about several $1,000s. I mean, a small amount by our standards, but a very large amount by the standards of these people in Addis Ababa, the capital of Ethiopia. And they were able to set up, they were provided by the municipality, they were provided land in a built-up area, and they set up a bakery and a store, and the store sells vegetables which they help prepare, process, package, pulses and other foodstuffs, and this bread which they sell. And they've been in business about a year now, and there were something like 30 or 40 former sex workers. They're starting to draw dividends. They have money in the bank. They showed, their deposit account in the bank, the money they're depositing. They now have a viable business, and can stand on its own 2 feet.
Yeah.
This is not. They're not living constantly on handouts. They were given the seed capital without which they couldn't have started this. There was another program we visited in the country, in the further north from Addis Ababa, and it was a farming project, and it was a group of about 160 people, all of them living with HIV/AIDS, who were giving 10 hectares. That's about 20 hectares of land, and they are working that land. They've given it over, they've got various crops, cash crops, which they're growing on that land, and they are really doing rather well. And in fact, the accountant who was working for that particular cooperative, because effectively it's a cooperative, was explaining to me that they've even bought an electricity generator, power generator, and they're selling surplus electricity from that generator to the village, and they're charging for it, and that's helping them, build up resources to grow their business. So, these are isolated examples, but I think they're I think interesting ones where if you think creatively, you can come up with very interesting programs to help people who are living with these diseases to look beyond just the treatment stage to how do I get on with my life? How do I build a sustainable life for myself? And these are people who are living with a disease which is still surrounded by a lot of stigma, and it's not just in these countries, in pretty much every country that you have stigma. And but this is allowing them to have self-respect and to support themselves and to be respected in their own communities as citizens who are supporting themselves and providing prosperity to the community.
Definitely. One thing we're trying to do is we want to get young people involved. We want to get and for me, I always think logically. I think I create a lot of to-do lists basically.
Right.
And I'm like, okay, what should prioritize? What should I do first? And if extreme poverty had a to-do list, where do you think disease would fall in line of priorities, or would you even look at it like that? Or, yes, if there was a to-do list for what we need to do to end extreme poverty, to meet the Millennium Development Goals by 2025, where does disease fall?
I think it's difficult to prioritize these sometimes. I think there are a lot of things that you have to deal with pretty much simultaneously, and disease is one of them. I mean, I think clearly you can't tackle disease if people are malnourished. If you want to put people on these treatments like ARV, you want to make sure they're being fed properly. On the other hand, if people aren't fed properly, then they're more likely to catch the disease in the first place. So I think all these things are linked up. Education. I think education is vital because it's a very important part. In fact, I've talked to you a lot about prevention when we're talking about HIV, but also talking about malaria, for example. But it's very important, prevention. It's one thing to put people on treatment but the trouble is that for every 2 people who are starting treatment, another 3 people are being diagnosed as HIV positive. So, the train is accelerating faster than we are able to catch up with it at the moment. I mean, I think we're closing the gap, but not fast enough. So education is absolutely vital, and that means, and I think we found that the higher the educational level of people, the more responsive they are to these prevention programs. They're less likely to indulge in risky behaviors, and they're more likely to use condoms, for example, than if they're not educated.
And even malaria,
in malaria, for example, we haven't talked so specifically about malaria, but the Global Fund has funded the distribution of over 80 million insecticide-treated bed nets. Now, that is providing protection to families all over sub-Saharan Africa, but also in parts of Latin America and the Caribbean and in different parts of Asia as well. And this is absolutely vital because small children below the age of 5 are the most vulnerable to malaria. I mean, if an adult gets malaria, their chance of dying of the disease, are not anywhere near as great as those of a small child with an undeveloped immune system. And that's where these bed nets are absolutely vital, because if children sleep under bed nets and the homes they live in are treated with the appropriate insecticide, their chances of actually getting the disease in the first place, of being bitten by a malaria-bearing mosquito, are dramatically reduced. And basically, we have found that in countries where you have coverage, something like, there's a sort of tipping point where when you get about 2/3 of the population is covered by sleeping under these insecticide-treated bed nets, then you have a very, very sharp fall in mortality. And this is what we're seeing in many countries, and particularly in smaller communities like in Zanzibar, which is an island and is part of Tanzania, malaria mortality has practically disappeared. And there are also parts of Ethiopia where we've seen very, very sharp falls of 60–70% in some areas of mortality from malaria, due primarily to these nets. And, because that's the first thing you have to do. It's not, and then also you have to be sure that malaria, when people do get malaria, is correctly diagnosed and is treated quickly, because unlike HIV/AIDS, which is a very slow developing illness, which actually takes many years to kill people, malaria, can kill people within weeks or days or hours. It's very acute, so it needs to be treated extremely quickly. And that's where, in countries like Ethiopia, it's vital to have access to treatment. And that's where you need, first of all the villages need to have somewhere where people can get access to these medicines, free if possible, or at an absolute minimum charge. But they need also access to diagnosis. And And education is part of that process, because they need to know to recognize, first of all, they need to know how to use these bed nets, that you can't just use them for fishing. You need to sleep under them, and they need to be set up in the home properly, and you need health workers to explain them how to do that, and also to make sure that everybody, all the children, the whole family, are sleeping under these bed nets.
What?
I had a quick question. Just David just gave me. Not really a big question. I was just going to ask if the nets are treated with permethrin, or which chemical are they treated with?
I'd need to check on exactly what. It's a combination of chemicals. My understanding, I think one of the key developments that we've seen in these bed nets is that the treatment and the insecticide repellent is much longer lasting than it used to be, and basically these nets now have a useful life of up to 5 years, whereas not very long ago their useful life was just a matter of months, which clearly makes it's already a logistical exercise in itself getting these bed nets out to people, but you need to see, you need to basically map how long are these nets going to last, and within 5 years you need to have a program to replace those. But if you're going to have to replace those within just a matter of months, you can imagine how much more costly and how much more difficult it is to do.
What if they don't have the insecticide on them?
Well, it's a requirement of our programs that they are treated with insecticide. I mean, they have to be approved bed nets, and they have to be procured from companies which meet the required standards.
Can we get one of those or buy one of those nets from you guys?
I don't know if we sell them here on the premises, but but I think we could certainly, if you visit any of these countries and you meet, or we can certainly direct you to the the recipients, basically the project managers, as I mentioned before, who are dealing with, who can certainly show you these nets, and certainly can tell you where you could buy an equivalent one, at a commercial rate. But my understanding is they cost about $10 now.
We have nets, they just don't have any. They're old. They don't have any.
You have old ones, and they're not treated.
Yeah.
Yeah, I think it is important. I mean, I slept under a treated one when I was in Tanzania, and I do remember. Actually, it was the one I took, and it was one of the recommended ones. And I remembered that the net was actually covering my face, which it should be. There should be a space between you, but it was just the way it was draped. It wasn't. And I remember waking up in the morning and my face was kind of stinging, actually. So that's obviously not the right way to drape, which just shows you need to know how to set these nets up properly, so they don't give you a less than satisfactory experience. But I mean, the important thing, if it was stinging me, I can imagine what it was doing to the mosquitoes who were trying to get in, which is the more important thing.
7 minutes left to table.
Yeah, I feel like there's so many questions to ask with this.
I just got 1 minute.
Got 1 minute. Let's switch table. Okay. Question. So yeah, we're thinking it's possible. It's very possible that one of us may get malaria. Just considering the prevalence of it, would you agree? And can you just talk a little bit about that?
I mean, as a matter of fact, my grandfather, who worked in Africa as a civil engineer as a young man, and he contracted malaria. And I hardly remember him. I was about 8 or 9 years old when he passed away. But I do have, I still have vivid recollection of what he was like. And I remember him telling us that he had recurrent sort of bouts of malaria symptoms for the rest of his life. So it was something that affected him for his whole life. So I'm very much aware of that. And another distant relative of mine, I believe, died of malaria in Africa. So, yes, the simple answer is this is a disease that you can contract, and you have to be very, very careful. The first thing is try not to get it in the first place. And the two ways to minimize that risk are sleep under bed nets and cover yourself, drench yourself in repellent. You can buy very, very effective insect repellents, and you can buy them here, and some of them are approved by health organizations like the Swiss Tropical Institute, and you want to take loads of that stuff with you.
Can you buy it in Africa?
You can buy it in Africa, but why not buy it here? You could go to any pharmacy here and you can buy it off the shelf. You don't need a prescription or anything like that. But you're sure to I would recommend that you have the stuff in the first place before you go there, because you want to be spraying yourself pretty much the minute you arrive. You know, you need to find out where you're staying, and of course there are many parts of Africa where...
Nairobi, there's no malaria.
Exactly, because of the altitude. Addis Ababa is the same. It's 2,400 meters above sea level, so there is effectively no risk of malaria there. But you can go in just a matter of hours in a car to an area where malaria is endemic, and you know, if it's just been raining or if you're there in the evening, you can find yourself exposed to the risk of being bitten by malaria-bearing mosquitoes. So if you are spraying yourself, and many of these sprays, you know, they last for many hours. So, but err on the side of caution. You know, if say it says the repellent is effective for 10 hours, spray yourself every 5 or 6 hours just to be absolutely sure, and make sure you spray all the exposed parts of your body, but even the less exposed parts, because these mosquitoes can get inside your clothing. So I think if you do that, and then you sleep under bed nets, you're pretty much minimizing the risk. You can never eliminate it altogether, but you are greatly reducing the risk of getting the disease. But you must be consistent, and this is what all these health programs are about, is being rigorous, sticking to the precautions. It's not just something that you do from time to time. When you feel like it, you have to absolutely be sort of manic about it, practically. So that would be the first thing I would say. Also, take medication with you in the event that you do, despite all the precautions that you may take, do contract the disease, and you need to treat it. But try, to get to a doctor first as soon as you feel any onset of symptoms, so you can have a proper test and a proper diagnosis, because sometimes people develop malaria-like symptoms and they don't have malaria, they have something completely different. So be very careful with diagnosis. Make sure that you do seek medical help as soon as possible, as soon as you have any symptoms which don't feel right. So take whatever you can to stop developing the disease in the first place, but get help straight away if you think something's not right.
If we got the malaria, what is the likelihood that, God forbid, we would die from it? Like, it would be deathly?
I think you're talking specifically in your case, or just generally?
Well, I guess in our case, then we'll talk about...
Well, you're healthy, you're young, you're resilient. My assumption is that you're going to be, first of all, you're going to be taking all the necessary preventive measures. And among those preventive measures, you can also take prophylaxis. So you can actually take medication, which practically eliminates almost any possibility of you developing that disease at all. Now, some of those medications are quite strong, and some people, suffer side effects, to a greater or lesser degree. So it's really, the choice is yours whether you want to take that. But I think if it's in the malaria season and you're going to areas where the disease is highly endemic, I think you should give serious thought to taking that prophylaxis. So, if you do all those things, I would say the chance of you developing the disease in the first place are pretty much zero, or very, very limited indeed. If the worst were to happen and you did develop the disease, assuming you seek medical help quickly, I would also believe that it is highly, highly unlikely, given your stage in life and given your, I'm not a doctor, but given you're generally, I assume you're young, you're all young, and you're clearly all very healthy. I'd say it's very, very low. It would take great misfortune, great misfortune.
What about for the average African? Like, what would happen, an average person living in extreme poverty, what would happen if they contracted malaria? And how often do they contract malaria, and how many people would you say, you think everybody's had malaria once, or?
That's hard to say. I mean, there are millions and millions of cases of malaria every year that are diagnosed. But often it's very hard to come up with these estimates, because it's hard also to diagnose every single case of malaria in a country where you don't have a highly developed. It's not like in the US, where you have the Center for Disease Control, and where everything is documented. It's very hard for anybody to get any disease, and for any disease to be serious disease to be diagnosed in America without the Center for Disease Control knowing about it, documenting it, and databasing it. And this applies applies for most developed countries. In in a lot of these countries, people don't even know how many people were born last year or how many people died, and that's simply because they do not have their census systems and so on, but they're not as developed and they're not as accurate. And of course, it's much harder to keep track of this in very communities where so many people are living in villages, outlying villages, scattered communities, where often telecommunications are rudimentary. I mean, mobile telephony is spreading throughout Africa, and it's probably one of the most dramatic changes that you'll see in Africa if you haven't been there for a number of years, is that a very high proportion of people now have mobile phones, and that is spreading, and it's going to clearly have an impact on rural Africa as well. But that said, it does mean that it's difficult to know exactly how many people are getting these diseases. However, we do know that mortality, something approaching 1 million people die in sub-Saharan Africa of malaria every year. And one of the reasons is because small children, a very high proportion of those are small children under the age of 5, and who are especially vulnerable to that disease. So I think you already have an advantage. You're already an adult, and you have a developed immune system. A child, and a small infant, doesn't have that, and therefore they are most at risk. And that's why it's absolutely vital for us to get universal cover for bed nets and to have universal free access to treatment to the necessary medication. And the medication that's now used is called artemisinin compound therapy, ACT for short. And this is a highly effective treatment now for malaria. And but that is quite costly, relatively costly, and the challenge now is to make that accessible to as many people as possible in Africa.
I'm very weird about diseases, and I'm very realistic about it, but immediately when he was talking about going to Africa, I was thinking, oh crap, I'm going to get all these diseases, and the more I did research on it, AIDS, I think I'll be fine on that. Malaria, it could happen, but the biggest one I was worried about is tuberculosis, just because my girlfriend's going to be a nurse, and she kind of just expressed you can get it through coughing and saliva and stuff like that, and I was really worried about the kids and running up and just help, and I just was hoping you'd talk a little bit about tuberculosis.
I think it's interesting you mentioned tuberculosis. I mean, it is a big disease. It's a killer disease. It's also a very ancient disease. I mean, it's a disease which has been around for thousands of years. If you read any literature up to really the early 20th century, just think of books, novels like The Magic Mountain by Thomas Mann, who's about a TB clinic in Switzerland, or there are many works of literature about people who die of what used to be called consumption. It was this wasting disease for which there was no cure, so I think TB has been around for a very, very long time. And
sorry,
you want me to look?
It's kind of his question. Sorry,
yeah.
I wanted to grab. Sorry.
And it's still, while it's pretty much diminished in its impact in richer countries, it's still a huge, huge problem in countries like, particularly where you're going to be going in sub-Saharan Africa. The Global Fund has funded treatment for over 5 million people since it came into existence. And basically the standard treatment now is called DOTS, that's directly observable treatment. And essentially what that is providing a course of antibiotics to anybody who's diagnosed with tuberculosis. And as you know, in order to find out whether you have it, you need a sputum test. So you need laboratory facilities to provide adequate testing and so on. The thing about this is that the treatment lasts for a number of months, and it has to be constant treatment. In other words, it's directly observable. So what this requires is that patients turn up every day to a health clinic and are given the medication and are seen to take the medication. That's why it's called directly observable treatment. Now, this is really important because we have seen there is evidence now of resistance to some of to these treatments, and that's one of the most one of the things that the global health community is most concerned about. Because what happens is, if you get, one of the reasons people develop resistance is that they'll start treatment and then they'll discontinue it, which means that their organisms develop resistance to these medications. And what we're now seeing is we're seeing evidence in some countries of what's called multi-drug resistance strains of tuberculosis. And this is essentially TB, which isn't totally untreatable, but is very, very hard to treat. So it needs to be treated for very, very many months. With very powerful medications. It is curable. It is curable. But what people are most concerned about is extreme drug-resistant tuberculosis, which is very rare, but nonetheless is out there. And that is practically incurable, extreme drug-resistant tuberculosis. So clearly it's all about making sure that when people are treated with TB, they're treated with it properly in a consistent fashion, and that they adhere to the full course of treatment, because we cannot, the global community has not yet caught up with extreme drug resistance tuberculosis with adequate cure for that. Yeah. And this is not something that we want spreading around the world. So essentially, tuberculosis is treatable, but it requires organization to provide and to deliver that treatment, and it requires funding as well. So that's, I think, absolutely vital.
David, you can come back to me.
Could you address the specific, you talked about how you could prevent it with malaria and stuff like that. Could you just discuss that a little bit? Does that make sense? What precautions should we take in order to reduce our risks significantly with that?
I think that's probably a harder one. I mean, I think you have to certainly keep your distance from anybody who if you go into a hospital, for example. I mean, I visited hospitals. In fact, I visited a hospital about a year ago in Central America where some patients there were being treated for drug-resistant strains of TB, and we had to wash our hands, we had to wear masks when we went into the particular wards where these patients were being treated, and occasionally healthcare workers do catch the disease, so you do have to be extremely careful. But to be honest, unless you want to wear a face mask at all times when you're in a city, which some people do because of pollution and so on, it is a risk that, particularly if you're going to find yourself in confined spaces like, in public transport or in sort of crowded areas, there is a small risk that you could inhale, that you could become infected. Unfortunately, that is a fact. But you can, so really you'd have to wear a mask, I think, to be absolutely, reduce to a minimum that risk. But I think that what you should do is when you return, you can take tests to make sure that you haven't contracted tuberculosis. That usually requires a chest x-ray. For example, when I came to work here, I was required to take a chest x-ray because I believe 1 in 3 people in the world can contract. They basically have, what's the word? They're potential carriers of this disease.
Maybe if someone coughs near us, we could just put our shirt over our mouths or something. I
think it might be too late. I mean, if somebody's coughed, it's hard to.
Can you?
But as I say, I'm not a health worker, so I can't. I can certainly make sure I can provide you with the best advice or direct you to where you can get the best advice on how to behave on that. But basically, we fund programs which fight tuberculosis. But I'm not a real expert in exactly everything you have to do to avoid tuberculosis. But the key thing is to give people treatment when they.
Can you tell? I mean, if they're the way they're coughing, or the way they look, or the way they're acting. I mean, are tuberculosis people just out there, just hanging out, living life normally? Or?
I think in its early stages, I think it's very hard to tell. But I think if somebody is seriously ill with tuberculosis, I think it is very, very noticeable. Absolutely, and because people do lose weight, they become feverish. But many people lived with tuberculosis for a very, very long time. And for example, Chekhov, the Russian short story writer and playwright. He died of tuberculosis, but I believe he had it for many, many years, and he had bouts of it. Where he was very ill.
When you take those antibiotics, does it make it? Are there antibiotics now that if we do get TB, as long as we don't get the rare strain, then we're...
Oh, yeah, no. Look, if you were unfortunate, I mean, I've known people who've had tuberculosis, and they were quickly diagnosed with the disease, and they took a strict regimen of antibiotics, and it was cleared.
And they're all good. And they didn't...
Absolutely.
Oh, see, I thought it remained with you as an active carrier for the rest of your life.
I don't believe so. I believe you can be effectively completely cleared from your system.
That's good to know.
Yeah. But I would suggest you look at the WHO website and look at the section on tuberculosis, and that will give you, and I'll be glad to direct you to that website and give you any more information that you need on it. But it's a dangerous disease. It's one you want to be aware of.
Definitely.
Yeah, and it does spread quite easily, but it's particularly, there's quite a big problem in Eastern Europe and the former Soviet Union, because in prisons because people living in confined spaces, it can spread very, very quickly. Particularly being cold countries, they have the windows, there's little ventilation, which makes it even more common.
Yeah.
And then there's a lot of, cross-infection. I mean, if you are, and this is particularly a challenge in Africa, that is, increasingly we're trying to build into the health programs we finance testing, so that if people that receive testing for HIV/AIDS, they're also tested, and they test positive, they also test for tuberculosis. Because very often, if you are HIV positive, if you develop full-scale AIDS, as you know, often people who are HIV positive, if they don't take tests, eventually they start developing secondary infections. And in other words, they develop other diseases which are brought about because their immune systems have been so depleted, have been so severely weakened. And tuberculosis often can develop in people who are HIV positive for this very reason. So it's very important that people who are HIV positive are also tested for TB, and that's not happening to the degree that it needs to happen. It basically needs to become sort of built into the process, because there is cross-infection, essentially.
No, that makes sense.
Yeah.
So, probably last question or two. So what can young people do? The whole goal of our film is to get young people in America and Europe caring about these issues, fighting extreme poverty and all that comes with it, including this huge issue of disease. Yeah. Make that a priority in their life. Make it one of the top priorities, just to do a little bit, just to do their little part.
Yeah.
What can they do?
I think people can do a lot.
For Global Fund, and what can they do just for the issue in general?
Yeah, I think young people can do an enormous amount. First of all, young people have got longer to live, so they're going to be around longer, and the people who are very young today, going to be, many of them are going to be tomorrow's decision makers. So, and I think because of the way the world works now and the way we're also connected up, this sort of interconnectivity, as people call it, you can actually communicate, you can keep abreast of all these issues and actually express your opinions vocally in a way that wasn't so easy before. I think that's one of the first things that young people, particularly young people in America, can do. But I think what they can do is also influence policymakers. These programs like the Global Fund are effective, but they need to be supported. I mean, for example, let's not forget that the world is going through a major economic crisis, a major economic downturn. Many people say it's the worst since the Great Depression, and unemployment has shot up in America. Many people who are leaving college now in the United States and in European countries, who only a few years ago would have been pretty sure to find employment, are now really struggling. I mean, I know people who are leaving elite business schools with MBAs are having a really hard time finding employment. So things really are getting tough for a lot of people. I think it's absolutely vital that young people are aware of how much money was spent on bailing out, for example, these banks, these financial institutions, which unfortunately have played a very large part in precipitating this economic crisis. Now, if the international community has been able to mobilize huge resources, and it needed to do that, nobody's questioning the need to stabilize the economic situation, we shouldn't forget that the amounts of money that are required to, for example, provide the world with universal access to HIV/AIDS treatment or treatment for TB. I mean, these are significant numbers, but they're not trillions of dollars. They're billions of dollars. They may be tens of billions of dollars, but they're nothing like the sums of money that have been mobilized to bail out the banks. And obviously the financial health of the countries we live in and the economic health is very important to all of us because our well-beings depend on that. But we mustn't lose sight of the fact that, while we're worried, while we're focusing on our own problems at home, that there are countries like in Africa which are with huge potential, and many of these countries are starting to realize that potential. I mean, Ethiopia, for example, which is a country of 70 million inhabitants, it has an economy which has been growing for something like 10%, at a rate of about 10% a year for a number of years now. This is significant progress. But nevertheless, they're growing from a very low base. These are countries which are nonetheless, where there is very significant poverty, and therefore they need help. But this help needs to be directed, and the way that help is given needs to be transparent. Everybody needs to know where who's giving that money, who's it going to, how's it being spent, and is that money being spent wisely, and are those aid dollars actually delivering the goods? Are they producing results? And if you come to our website, and like all websites, it takes a little while to navigate it because there's just so much information on it, you will see ample evidence that we have nothing to hide about our programs. It's all out there. All the money that we are committing to these programs is detailed in the most painstaking detail. And that money is being well spent. And on the few occasions where the money has not been properly spent, we make sure that people are called to account for it. And there have been cases where aid programs have been suspended because we're simply not satisfied that they were that either the money was being spent. There were concerns about money was possibly even being misappropriated in some rare cases, but the programs weren't achieving the results that the people who thought up those programs and designed them in the first place said that they were supposed to achieve. So, so what I would say to young Americans is, America is, with all its problems, it's still a remarkably rich, dynamic country, which is in a privileged position to provide help. And this applies to many European countries too, to these countries which need it very badly, but they need smart help. They don't need blank checks. They need help which is directed to fix certain problems. And if they don't fix those problems, it's just going to make it much harder for them to grow and to develop, because one of the first things that you need if you want a healthy economy is a healthy workforce, a healthy population. You want people who can get up in the morning and go to work. Now, if you have people who are burdened with HIV or with malaria, who are at the mercy of these diseases, these are very debilitating. Apart from the fact that they're killer diseases, they are debilitating diseases even for people who survive them. So it's absolutely vital that young people in America are aware of that America, for all its problems, its status in the world is not diminished. It is still the richest country in the world. It's likely to stay that way for a very long time in the future. And as so, it's in a privileged position to be able to influence the outcome in countries that organizations like the Global Fund are trying to help and to support.
So you'd say lobbying and
absolutely. Lobby your local Congress people, lobby your local senators, lobby your political representatives. Keep reminding them that America is one of the mainstays of the Global Fund, and the Global Fund is doing good work. But that good work, we don't want that to come to nothing, because the world doesn't basically stick to the course and see through this project, because essentially, we are. This is not pie in the sky. Within our generation, your generation in particular, within your lifetime, it is perfectly conceivable for all these diseases to be beaten. It doesn't mean they'll entirely disappear, but they can basically be eliminated as major public health challenges in practically all countries in the world. This is something that is achievable, that we can do. But resources have to be mobilized, the effort has to be sustained, and we have to all see it through together. This is a global project because we live in a global world, and these are diseases that spread around the world. And also, you can't contain them to one country, and we've seen with the swine flu epidemic. I mean, these diseases spread around, and so it's vital. We live in a joined-up world, and we need a joined-up strategy where the whole world, joins hands and fights these diseases.
So they say they can end extreme poverty by 2025. Do you think we can? I don't know how you'd say, get it under control and give the medicine the needed resources? Do you think we can to these 3 diseases by 2025 as well?
I think we can go a very long way there. A very, very long way there. I mean, if in 7 years we now believe that over 1/3 of the people who need antiretroviral therapy are getting it, it's perfectly, one would hope that in just a few more years, practically everybody who needs that treatment will receive it. But there's another side to the equation. It's not just the people who need treatment, who have to get that treatment. It's also preventing people from getting the disease in the first place, and that is a very, very big task, and that's educating people. It's showing them how they can, by changing the way they behave, by taking necessary precautions, they can absolutely minimize those risks of contracting these diseases, whether we're talking about HIV or malaria, but also TB. I mean, all these diseases can be, vastly reduced by adequate sanitation, education, obviously, so people, know how to lead healthy lives, know what kind of precautions they have to take. It's a multi-pronged strategy. But yes, I do believe. I mean, these targets are useful because the whole world can join in a common purpose, and even if we don't quite get there, you can go a long way. And I think that's really what we want, is to make a real difference. And whether we go all the way to eliminating poverty, often it's a question of how you define poverty, and different people define it in different ways. But I do think that we're seeing, particularly in some of the countries which have been kind of mired in poverty and low growth for so long, we are seeing signs that some of these countries can grow in a sustained way, and many African countries have now been growing for a number of years, and this gives great hope that combined with smart strategies to tackle disease and malnutrition, that these countries can beat these problems.